So thank you very much to our first speaker. We're going to move on, and our second speaker is Reine Rutagwera, who comes to us from Zambia, and she's going to speak on community health workers, scalable foot soldiers for active surveillance and case management for malaria elimination in Zambia.
Okay. Thank you all for coming. Today I'll be sharing my experience in Zambia working with the community health workers. So as we may all know, Zambia has committed to eliminate malaria, and this requires a number of things, where some of them are proper planning, management, and resources. And then also it requires a packaged approach which guides interventions where they should be taken, where they are most needed. It also requires a timely and quality surveillance system which helps to pinpoint the exact location where those interventions are needed, as well as a ready and willing workforce which is committed to join the fight for a common goal. One of the critical strategies that is being deployed in Zambia is engaging community health workers. And these community health workers are chosen by the communities themselves, approved by their community leaders to serve the communities. And in this way, it helps to retain them because they are working for their own communities and their own people. Then we train them to test, treat, as well as follow up all the malaria cases, which helps to guide interventions at a more granular level. It also serves as a platform for extending integrated community case management, as well as other malaria services such as ITN distribution, use promotion, IRS, and many others. So as we train these community health workers, we get to have a bigger workforce that is able to address a range of illnesses. They are also able to provide community awareness and sensitization to malaria-related issues as well as other health issues. So that is the map of Zambia, and the red dot represents, these red dots here, they represent the health facilities, and then we have the green dots that represents the community health workers. So we can see that as we add the community health workers, we have increased the point of care of services for the patients. My talk today will concentrate on the highlighted area, this one, which is the Southern Province, where we have 1,690 community health workers who are trained. So in Southern Province, we have 13 districts and about 300 facilities. So with the trained community health workers, we've increased the point of care to about 5 times what it was before the addition of community health workers. This intervention started in 2011, and we kept rolling out. We completed rolling out Southern Province in 2014. We had some districts that still had a lot of malaria cases, so it took a bit longer to finish rolling out in the whole province. So what has been a challenge to accessing health services is the distance that patients had to travel to the facilities. So what we have here is the work that was done along the Lake Kariba in Southern Province by the Institute of Disease Modeling. And from the map here, this was before 2014, and this was after 2014, after we completed rolling out the community health workers. And we can see that the minimum distance that patients had to cover ranged from less than 1 kilometer, which is in blue, to above 20 kilometers in red. So we can see that where health facilities were offering the health care services before the addition of community health workers, most of the patients traveled more than 20 kilometers to access care. Whereas after the addition of community health workers, the distance was reduced to less than 5 kilometers. So with this surveillance system in place, people are able to travel at a shorter time to access the treatment that is needed. We all know that it is critical, the time between the onset of symptoms, diagnosis, and treatment is very critical to elimination settings. How does it work? So these community health workers, like I said, they are trained to test individuals that go to their households, which is here. And then we have other patients that all prefer going to the clinic. So whether they have gone to the facility or they have gone to the community health worker post, they are tested for malaria. And any positive case that is found, which we call the index case, is followed up in the community. And when the community health workers make a follow-up, they start with the index household, where that index case came from. So first they start by notifying them to make an appointment that they are going there to ensure that they find the family members. And then they also cover neighbors within 140-meter radius. They will test and treat only consenting members. Those who have not consented, they are not tested, and they are only treating those who are found to have malaria. It's also important to note that all this is entered in registers. We have what we call a passive register and an active register. So the tests that are done at their household, they use the passive register, whereas the ones done in the community, they use the active register. Then they report to the DHIS2 via a mobile phone. They report to the DHIS2 via a mobile phone, and thereafter it can be visualized by stakeholders from the facility to the national program, as well as partners who have access to the system. They can be able to analyze it. Those who are not able to analyze, we've built in some dashboards that they can easily access to help guide them. So what happens after the rollout? So soon after the rollout, we see that cases tend to increase relative to the facilities with the addition of community case management. Mainly this is due to the increased service availability closer to underserved communities. And then thereafter, with the addition of data coming from the community, it takes about 1 malaria season to stabilize, and in order for us to get a new baseline, and it takes a couple of years for us to be able to notice the benefits of the intervention on a trend line. So now showing you what happens in Southern Province. This is from 2013 to 2017. So in 2013, we had not completed rollout. Rollout finished in 2014. So around here, that's when we can say that most community health workers were trained. So we can see that even though in 2014 we had high malaria incidence, the addition of data from community health workers tends to increase relative to the facilities. So we can see that with the yellow shows the community health worker data, and the red through reactive case detection. So yellow is through passive, and then the brown one is from the facility. So if we had not added community health worker here, these cases would have been probably slightly higher than what it is now. But with the addition of community health workers, with more access to care, we tend to see that the cases are higher. Then as time goes by, we see that cases at the facility start reducing, and the cases being identified in the community start increasing. This decongests the facilities, giving a chance to the facility staff to attend to other health issues. Then The gray trend line here shows the percentage of passive cases that are actually identified by the community health workers. So what we have here are the red, which is the total cases in Southern Province. It ranges from 2014 to 2017. And the green is the contribution of the community health workers. This is both at passive and active. The first graph just showed during passive case detection. So we can see that malaria incidence dropped from 113 per thousand in 2014 to 37 per thousand in 2017. And in 2014, about 31% of the confirmed cases were identified by the community health workers. This is both passive and active. And then in 2017, we have now more community health workers identifying more cases, which means that the facility staff can now attend to other issues. Actually, the OPD malaria cases reduces a lot. So, apology, the slide is a bit busy, but I will try to walk you through. Basically, what we are trying to show here is an example of the dashboards that we built to help the managers and other stakeholders be able to see what is happening at a more granular level. So the district is Mazabuka district. It's in Southern Province. It's the district that has the lowest malaria incidence. As of 2017, it was at 5 per thousand. So what we are seeing here is a map that shows the health facility location as well as the incidence level. So if you are trying to plan for an intervention, it's very easy to see which areas has more malaria and be able to target as such. And then at the bottom here, we have community health worker location. So you can see not just at a facility level, but also in the community where exactly that intervention is required. And at the lower part, we have now the passive and reactive case activity. What is going on? How is the system performance? Are the community health workers working? And if they are working, what are we really finding? So the bottom line to this, in this same district, which is Mazabuka, for every 18 passive cases that are followed up, one additional infection was found during 2017. And then the passive case positivity by community health workers is at 1.5%, whereas the reactive case detection positivity is at 1.6% in that area. What are the lessons that we've learned? So working with the community health workers, what we've seen is that the cost for scaling up is affordable, and this has been documented. There's a study that has been done by Larson. It costs about 1% per person per facility catchment area for both active and passive components. So by linking community case management through integrated community case management and surveillance, the Zambia National Malaria Elimination Program, it developed a single scalable platform that is currently being used to roll out in other areas, not just in Southern Province, but also in other areas to meet the elimination needs. We realize that in some of the areas we still have high malaria cases, but we need to set the system right as we plan for other interventions to reduce the cases. For areas with few malaria cases, integration of activity at community level is very critical. Because once the malaria levels go down, some community members may choose to bypass the community health workers and go straight to the facility. And if we have any resurgence, it may be difficult to kickstart those community health workers. So we have to make sure that we keep engaging them with other community health, other community work that they are able to do. Expanding case management and reactive case detection requires a significant system strengthening to improve logistics. So we need a system that is able to tell us where the amount of commodities that we have or what we need in a particular area in a timely manner. If we don't have that, it will be very difficult for us to plan. There may be stockouts which we may not notice, which may lead to resurgences. So we need a system that is very sensitive. Number 5, focal drug administration may be a better option due to the inherent challenges in the tools. And then also, I could add the workload with the community health workers having to follow large areas. So if we deal with focal drug administration, a number of studies, I think most of you heard in this conference, a number of countries are going focal. So maybe it may be better even for us to move that direction. Saturating the number of community health workers per population is key. Saturating the number of community health workers per population is key to being able to meet recommended % of index case follow-up. Would love to be able to follow up all the cases that are found, whether at the facility or at the community. But this needs a particular number of community health workers. In Southern Province, where we have low transmission, we do 1 community health workers to 850 population. But in high transmission areas, we are looking at 1 to about 500 to 750 population. In active follow-up, there is growing evidence suggesting that further positives are primarily found in the index case house. So when follow-ups are being made, cases that are related to the index case are more clustered around the indexing house. And there is a study that we've just concluded, which also tends to show that about 90% of those cases are being found in the index house. So should this be our next move? Now that's the question that we need to be answered. In conclusion, timely, quality, and focal data is essential as we pursue the malaria elimination. We need to make sure that the system that we have is able to provide data in a timely manner, and that data should be of good quality. Because if data is not of good quality, then we may plan to fail, if I may put it that way. We need to make sure that we are talking to the quality data. In Zambia, community health workers are chosen by their communities, providing their home areas with convenient and free health services, not just malaria, but other health services as well. Trained and equipped in surveillance, community health workers are trained and equipped in surveillance so that they are able to serve on the front lines, contributing to Zambia's push to eliminate malaria. I would like to acknowledge my colleagues at PATH and at the National Malaria Elimination Center, the Institute of Disease Modeling across Global Health, our funders, Bill and Melinda Gates Foundation, the provincial and the district teams that we work with. But above all, I would like to thank the communities and the community members that we work with. Without them, this would not be possible. Thank you.
So we have time for one question, if there are any. Can you step up to the microphone? And please identify yourself.
Francisco Saúde from Manisa Health Research Center in Mozambique. But my question is on the community health workers. Are they malaria specific or they are ICCM workers? Are they paid or not? If they're paid, how much is it paid and who pays for it? If they're not paid, how do you manage to keep them, incentivized, and sustained over time?
Okay. So the community health workers that we use are volunteers. They are not paid. And like I said, they are selected by their community members. And the retention is actually very high because they are motivated to work for their own people. Some of them have even said that previously they used to see a lot of malaria cases, and as they see their children playing and without malaria, they are happy. So they are not paid. The other question is on, I think I missed that one. Sorry? Okay. Thank you.
Okay, maybe one last question.
Okay. Hi, I'm Nina Brunner, Swiss TPH from Switzerland. My question is about the reporting system. So I was wondering, how does data that is collected by community health worker eventually end up in DHIS2? So what tools are you using? How does the notification system work?
So the community health workers have paper registers where they write. Then at the end of the month, they aggregate the data and report via a mobile phone. It's a feature phone that we use. We use the mobile client from DHIS2. But that report comes per community health worker. So we're able to see per community health workers how they performed in that particular month. Yes.
Great. Thank you,
Thank you.
Maria.